Hey, Dr. Greenbaum. This is your patient Fred. A few things I wanted to go over. Very good case for you to get your feet wet. First things first, I had placed some implants many years ago. He had really infected number 18 and 19. One of those situations where the infection started on one of the teeth and then encompassed the neighboring tooth. And I think that ultimately led to why he has some bone loss around one of the implants. Just not something I typically see. When I do, it's typically associated with a site that had some profound infection. With profound infections, we can assume that there's some sort of anaerobic component, and there is literature supporting that anaerobic bacteria tend to harbor in the bone for a period of time after removal of the teeth, or something to that effect. Something we should dive into a little bit more together. But long story short, the implants on his left side are stable, but there is some bone loss around, I believe, both of the implants at this point, although it looks decent on this CAT scan, which was taken a year or two ago. I did talk to him about removing them. I talked to him about grafting, cleaning the implant surfaces and grafting, so on and so forth, and he ultimately decided to just keep them as is. If they do get worse, then we're going to replace them. So I just wanted to give you that heads up as a backstory to this guy's case. We love for things to go perfect. They don't always go as we planned, this being one of those cases. With that said, I don't think there's anything in the site that you're going to be placing that's going to put you at risk for having any issues with the implant. So we're going to treat this like a normal case. But just be aware of what is on the other side. He does have crowns on these at this point. This image was taken sometime after the implants were placed. So, first things first, how do you draw a nerve? You want to know where this nerve lives in relation to the alveolar ridge. So let's go ahead and do that together. If you click, so I'm on the arch section here, under nerve pathway, click new nerve. And then as long as you select the nerve in a two-dimensional image, it will typically find where it is in the third dimension. The software definitely has some sort of AI component to it where it can do that. But I'll typically start with the pan image, and then I'll just click. Let's try that again. Alright, let's try that again. So I start at the opening to the mandibular canal, come down, and I'm trying to stay in the center. Basically, I'll keep going until I can't see it anymore. And a lot of times with patients, you'll lose visibility of the nerve right around the first or second molar area. I can see it more here, but I just want to show you what I normally will do. I'll take this green line, and then I go to the more mesial aspect of where I did trace, and then let's see if I go to, so I'm in the pan view now. Yeah, of course it was going to do that. I want to go back one. So node here, I should be able to delete. The node is kind of it's a more recent extent of the nerve. For some reason, it's not showing me the ability to do that here. This is a new version of the software, so there are some things that are different. Okay, so I guess that takes care of that. I'm going to hit done. Normally I would be in this view here. I would just trace it down. I double click just to start the conversation with the pan view. Again, I'm in the arch section here, and I had double clicked on this to bring it to that view. If you double click back, it brings you back to this view here. The problem is when I double clicked, I don't know how to go back with the view. I'm sure it's maybe up here, but essentially it was trying to continue the nerve to where I had double clicked. Basically, you'll see something like this. Take the green line, and you're going to go to about here, and then you look over here and you say, okay, where in this image? Let's go ahead and zoom this in. is the mandibular nerve. Then what I'll do is I'll kind of go back and forth and say to myself, are they in the nerve canal based upon what I see right here? It looks like they're off a little bit, which is okay. We picked the correct, we'll call that the vertical position. They just picked the wrong horizontal position from the axial view. So what I'm going to do is I'm going to follow with my eyes that canal until I lose the border. So I'm following this right here. Let's go back. Okay, I know that's the nerve. That's just what it looks like. There's really nothing special here. I will say more often than not it gets it correct. I'm sure if we deleted the node and did it again, it would pick it up. But I'm going to follow that with my eye. There's the nerve right there. So I'm going to do new nerve. I'm going to click that spot right there, and then come over here and click right in the center there, and it just connected the dots. I'm going to keep going. Typically at this point I'll go until I see the mental foramen right there, and then I select that, and then I come out here and select that. There's my nerve tracing right there. Again, right here might be a little inaccurate. That's fine. I'm not. That's plenty of bone there for you to place an implant. If you did want to get more exact, then you could go back through and delete this node and correct it to go inside that channel there. But I'm confident where the nerve is traced after that. Okay. Just to drive the point home, let's do it on the other side. So when you're done, come over to nerve pathway, click done, then new nerve, and I'm going to do this quickly. 1, 2, 3, 4. Don't know why I'm counting. I'm going to come over here. I'm off by quite a bit. It normally is much better than this. I'm not sure why it's doing that. So the other way to do it is to look at your axial view until you can see the nerve. Click like so. And now it knows where it is in the axial view. Let's see if it continues there. Yeah. I don't know why it keeps wanting to come outside there. Let's delete that. I'm going to stay in this view here. By the way, you can also use this view up here. That's not something I've necessarily done. You can see the nerve channel, fairly clearly sometimes, like right here and here. Let's just see what happens when we click right here. Let's see if it connects the dots. It did. Yeah, so it did a fairly good job of delineating the canal there. And then once you get to the mental foramen, I'll go like this. It knows where the channel is between this point and this point, and it connects the dots. So it does a fairly good job of that. That's why when you click outside the alveolar housing, it will typically do a good job of that. And then to double check your work, the nerves should be fairly bilateral. They should look fairly smooth coming down. There should be no sharp undulations left, right, and forward, up and down. If you draw the midline, the two mental foramina should be relatively the same distance away from the midline. You don't need to do this on every case. I'm just trying to give you a sense of how to do it if you ever need to trace both nerves. Maybe for an all-on-4 case is a good time when we decide to do something like this. But we're only looking over here. So I've traced the nerves. I'm going to hit done, and then I'm going to go over to implant. You can place the implant in the three-dimensional view. I find it's somewhat difficult, especially if your view has, say, the spinal cord in the back. So I'll typically, because it'll end up sometimes choosing the spinal cord, all of a sudden you have an implant in C4 or C5. So I go over to Pano implant a lot of the times. I find this is more efficient. And then I put the implant in the two-dimensional view. And then you can see it brings up these two other images here. Go ahead and place it in the center. You can do quite a bit of fine-tuning here. And then you can come back over to 3D implant, and then you get the three-dimensional view. Like so. It often helps to do clipping. So if you click that, here it shows the left side of the patient where we're focusing on the implant on the right side. So click flip, and now you only have the right side. Of course, the left side nerve stayed in there. But it's a much cleaner view to look at what you're trying to work with. There are ways of cutting out excess information. I believe that's in one of the other sections. Topic for another day. But essentially what I'll do here in the three-dimensional view is get the implant oriented the way that I want. As you can see, there's plenty of bone here. It does slope, so maybe you were commenting on the fact that he might need some bone grafting. You could make that argument, I guess, but most patients don't have anything close to this kind of bone. The only thing you're going to want to do when you place the implant is reduce this peak of bone here. So you want to create yourself a flat surface. How do you know how much to reduce? We're going to figure that out by placing an ideal implant that is surrounded by bone on the buccal and the lingual. Obviously, if you did something like this, you don't have any bone to the buccal on the superior part of the implant. So you place the implant where there's sufficient bone, buccal and lingual, pending you have enough space before the nerve. In an ideal scenario, we have 2 millimeters away from the nerve. This is probably closer to 3 or 4. Looks like almost 5, 4.5. So plenty of space for you to place a nice implant there. What length is this implant? It's 10 millimeters. It's a 3.5 millimeter wide implant. So using the nerve to assess your risk of involving the nerve is important. This is a very good case for you to get your feet wet. Just double check your depth control as you're doing the implant. You'll be fine. You can choose the specific implant. So if you go to BioHorizons, we use the Tapered Plus and the Tapered Internal. We also use the Tapered Pro, which isn't in this library yet. But I don't really find, unless you're doing a guided case, I don't find it that important. Even for guided cases, I could make the argument that that's unnecessary information. But long story short, you can choose the implant you want. It does have the right widths available for you. If you can, 4.6 is great. You're asking the question, how big should you go? We could talk about that for hours. But I think in this particular case, a 4.6 by 10.5 is perfect. You might, actually, I might even go to a 5.8. And the reason for that is you want to be able to have a wide platform that starts to extend to the adjacent teeth. The narrower the implant, the narrower the platform, the stronger the emergence. There's a conversation that could be made that we should try to go as wide as we can if we have the bone. In this case, we do. So I think 4.6 or 5.8 is good. All right. You'll take off probably a millimeter of bone. We can talk about how to do that on game day. Looks like maybe 2 millimeters. And you're just going to create a nice flat surface so that when you place the implant in, the implant has nice bone on the buccal and the lingual. This will be a beautiful implant. All right.